Well, folks, you are on for a treat on today's podcast because despite the many weeks me and Dr. Banerjee have actually worked on until we were able to secure this podcast, both of us promise will be well worth your time. Dr. Banerjee, welcome to the Healthcare Unfiltered podcast. Really appreciate you coming on with me.
Thank you, Chadi. I'm really excited to be on. And what an important topic that you've chosen to address in your podcast. I think, just talking about, in general, end of life, it's something that none of us are immune to. And I think all of us could benefit from learning. So whether it's myself or patients or caregivers or family members, there's so much to learn and so much to teach. So thank you for allowing us that opportunity.
No, I appreciate it. And yeah, I mean, it's a very sobering topic to talk about, but and hopefully we'll be able to leave this podcast with a little bit more of an uplifting message to everyone who's listening or viewing this. But let's start by getting to know you a little bit. I mean, what got you into medicine? What got you into this? And I know you wear a lot of hats at the City of Hope. We'll get into this, but tell us a little bit about you.
Thank you. So my journey into medicine is quite a unique one. I never intended to be in medicine, even from childhood. Even coming from extended family members that were doctors, that's something I never really wanted to do. I wanted to study literature. I wanted to write. I wanted to become an author. I wanted to write novels. And so my undergraduate was in literature and women's studies. But then, life matures you. You get your wisdom teeth, and then you decide that, how can you make a difference in this world? So I ended up, after my undergraduate, doing a master's in public administration at NYU, which really opened my life to public policy, really the inequities of healthcare that were present at that time, which are not very different from the times today, and really propelled me into looking at public administration as a path for myself, because it allowed me to work with populations that needed help, whether it's from a policy perspective or even providing services. And my goal was to, work in public administration, whether it's hospitals or government. Lo and behold, a year after I started my job in that field, my father actually died rather suddenly, secondary to complications in complications from his hernia surgery. This
From a
was
hernia surgery.
from a hernia surgery, and now keep in mind he was visiting India at the time, and he was only there for 3 months, and his hernia popped. The issue was that he was not the best candidate for that surgery at that time, anyways. He had suffered a couple of heart attacks in the past decade prior to his surgery. And his post-op course was going to be very complicated. If I think of it today, and what I've thought about for the last 5-10 years, is that he was actually probably towards the last 3-4 years of his own life, with his heart function being extremely minimal. He would have been considered someone who would be sort of in that last phase of his life's trajectory, if we were to look at his issues today. But I didn't know any better. He was in India. It was a sudden surgery, and the surgery resulted in complications and sepsis, and ultimately urosepsis, that really wasn't managed the best way possible. He should have been in the hospital, but I don't think people at that facility understood it as well. And so he very rapidly went into urosepsis and died. And the scary part is that, some people believe in, having people come to you before they die, or, it's something very common that we see in palliative and hospice care, that loved ones sort of reach out to you. 3 days before he died, actually dreamt his entire funeral. And so when I went to that funeral, it wasn't more a shock for me. It was more like
You
a
dreamt
calling.
you dreamt his funeral.
3 days before he died. And it was nothing different than what I had dreamt it to be in reality. And for me, I took that as a clear calling for me and my life to change my trajectory and make a bigger impact than I was going to if I had just continued in the field that I was doing. So hence I packed my bags and I went to medical school. And I went into pediatrics because, at the time when I was working, I worked with the pediatric population in Medicaid managed care. And so I was very aware of the needs there. But once I was in pediatrics, through my residency, I really, and through medical school, really, what was very apparent to me that back in those days and even today, everything is about cure and looking at how we can fix things. But the fact is that people do die, kids do die, and we need to provide them with as good care when that time comes, right? So for me, it was more a mission to enter palliative and hospice medicine with the understanding that, our lives are like a storybook. We have a beginning, we have a middle, we have an end, and there are so many characters along the way. What is not good is that when people reach that end of life, is that even in the medical community, we often don't know how to work with these patients, right? We sort of almost are scared, we give up hope. But what we need to understand is the same kind of hope that exists in when we take care of people that are living, the same kind of hope that exists then is the same hope that should exist in terms of providing quality care when people are nearing their end of life, right? Because once the disease comes to that point, we know that we can't cure it. So why take away from providing them with the best end of life care that there is? And that became my mission, not only just to do palliative care, but really change perspectives and attitudes and practice around end of life care, not only in medicine, but in all the other fields that touch it.
That's amazing. That's really very touching and an amazing story. And I'm going to try to get back to it as we continue with this podcast, because there's a lot to unpack in what you actually said. And there's obviously a lot of reasons why people fear addressing this issue. Then, if I may, I'll call you Chandana. That's
Chandana is fine.
Yeah, Chandana. How did you get to City of Hope? When did this happen?
Yeah, so I started at City of Hope about 9 years ago. Prior to that, I had done my palliative care training at Kaiser Sunset, Los Angeles. That's where I did my fellowship. And after that, I actually got recruited to a hospice. I worked at that hospice almost for a year, and I was about to sign my contract with them when I was alerted to this job at City of Hope, and I interviewed for it. And, when I realized that this job really allowed me to make a change, not only just at the end of life, but also throughout, because at the core of everything palliative is quality of care that should continue from the beginning of a disease all the way to the end of life. I felt like this would be a place that would allow me to make that change, right? It's a great cancer center with incredible therapies, incredible innovation, lots of clinical trials, and the patient population is extremely unique. So while I but while I worked for my hospice, I interviewed here, and then I told them that I would join them about 3-4 months after I interviewed, just because I needed to continue and fulfill my obligation to that hospice. And that has worked out beautifully. So that's how I ended up at City of Hope. And I can't imagine anything other than this path that I've taken. It has been incredible, not only just for me personally, very gratifying, but the ways we have been able to change things, the ways I have been able to also endorse and create things in the field of end of life care has only been possible because of City of Hope and what it has to offer to patient care overall.
Chandana, you progressed in your career at City of Hope, that you also have a deanship right now.
I do.
What is that? What does that look like? And what kind of part you're a dean of what, but also more importantly, how are you able to do it all, I guess,
To
between,
balance.
right?
Yeah. So that's a very good question. Sometimes I ask myself that, and I feel like when you ask yourself that, you want to do even more. So I've stopped asking myself that question. But let's put it this way. So I started off at City of Hope with in palliative medicine, 100% clinical when I did, with two major goals that I wanted to achieve. One was I wanted to create a palliative care and hospice care fellowship at City of Hope because City of Hope didn't have one. And, an NCCN designated cancer center, us being that, we would be the first of its kind on the West Coast. Okay, so it was very important to me that a hospice and palliative fellowship came to an NCCN designated cancer center. And we also cancer and diabetes care, which often people really don't know if they're not in the world of City of Hope. But diabetes is another disease where palliative care could really make an impact from the very beginning because it is a disease that becomes detrimental if not taken care of, right? So that was one goal. The other goal was that I wanted to create an end of life symposium, which was basically to bring together all the fields, the multidisciplinary, interdisciplinary aspects of palliative and end of life care, and create a symposium that sits out of a cancer center that actually could impact nationally and internationally and educate people. So when I started off as a clinician years ago, it allowed me, and along with my clinical care, to develop these two programs. We brought the Palliative and Hospice Fellowship to light in 2018. Our first class started 2019. And then we brought the End of Life Symposium. The first one was in 2018 as well. And now both of these have become extremely recognized. Our Palliative Fellowship has a 100% match rate for jobs. We get excellent candidates. We take 2 candidates per year that train. And then with the End of Life Symposium, it is national. We reach people from all disciplines across our country. We reach them internationally. For the last 2 years, it has been in Las Vegas, and in May of 2024, it will continue to be in Las Vegas, but we always have max capacity that gets filled up. And people actually come to the symposium, which is usually a 3-day symposium of workshops and speakers and networking. And every year they tell me that they leave this conference more energized than when they come in. So that tells you really, end of life care does not have to be a morbid topic to discuss. It should be a topic that we should discuss like in any medicine, right? You should look at the whole person.
But you can understand, it's, oftentimes at these meetings, at these conferences, what gets attention in general is like the new sexy drug on the block, the new medical device, the new procedure, the new imaging study, something that gets approved, things of that nature. So people who dedicate their life to end of life care and palliative care are so commendable, but I can understand the hesitancy because it may not always get the academic clout that you really wanted to get. Can you see that?
I absolutely see that, and it is a field that appeals to certain people. Like you said, we're not inventing a drug. We're not looking at any fancy clinical trials. We do have research in palliative care, and we've had people like Betty Farrell and Ida Bana and all present on the various things that are happening in hospice and palliative care. But the beauty of this conference is really it looks at the human aspect of end of life, which is the most critical part. Because even when patients reach the end of life in a medical center or a hospital setting, it's the humanism in that can make that journey a peaceful one, right? And if providers or clinicians and nurses and the interdisciplinary staff that takes care of these patients really don't know how to approach it, it can become a very unpleasant journey. The other thing that we do in the symposium is really look at how end of life is looked at in the world, for example, or in really our day-to-day lives. This year, we have a panel on, the first responders. If you think of it, firefighters, police officers, EMT professionals, right? They see a lot of end of life. But we as society have never looked within them or asked them, really, how do you see it? And what can we as a society do to help you? And services that can be created for people such as you that are seeing end of life firsthand. When you go into a house and have to pull out dead bodies, when you have to look at a, a victim of gun violence. This is all end of life, and it happens around us all the time. So the whole goal with the symposium is just to look at end of life from a very whole person perspective. It should be that something that we all as society think of and don't make it such that we are afraid of it.
That's amazing, and you get, I mean, I don't know how big the conference is, but the fact that it's always sold out and it's amazing, and I look forward to attending, maybe not this year, but the year after.
Yeah.
This is really wonderful, and this podcast hopefully will be airing around that time. Um, and then you are involved in graduate medical education. Is that
Exactly.
outside of the fellowship for palliative care? And
Yeah. So about 4 years ago, because I had experience with creating fellowships and I was always involved in graduate medical education, I was asked to take over graduate medical education at City of Hope. And GME is where, physicians, once they're done with medical school, go into training, right? So they go into residency or fellowships. Now, a center such as ours has one residency, which is radiation oncology, but we have 18 other fellowship programs. Half our programs are ACGME, which is, the accreditation for graduate medical education, where physicians get specialized in something after their residency, and then they get board certified in that. The other half are non-ACGME programs, which means they're super specialized, that even ACGME does not have a specific certification for them. But these are like the super, super specialized training programs. For example, our bone marrow transplant program, right? It trains physicians that are already hematologists to get even more super specialized in bone marrow transplant, right? So we have such programs that are really cutting edge programs. And I oversee all these programs. So all the trainees report up to me from the program, from the education perspective, but the program directors work with me on making sure that the training is adequate. We have about 45 to 50 trainees, depending on the year. And, from the time I've taken over as the director and dean of graduate medical education, we've actually doubled our programs. And we've created many more that are necessary in the field of oncology and hematology. So that's what my role is for graduate medical education. I still maintain my clinical care for clinic. Once in a while when I'm requested to go see patients inpatient by doctors, I still do that. What I've realized is that once you connect with your patients, they don't want to let you go. So I could,
no,
even for myself, I would not be happy if I wasn't maintaining that clinical piece to my repertoire. So I
you
do
have you
wear
have a
that.
clinic, you have an outpatient clinic, you see
I
pediatric
do.
patients?
I see actually primarily adult patients. So I most of my patients are adults, and then the adults all the way to like 100 years old. And I see many of the complex patients that City of Hope has, where the symptom management is very complex, or there's really extensive needs for goals of care discussions and communications. And I also actually oversee all the medical aid in dying programs here at City of Hope. So, the medical aid in dying program is called the End of Life Option Act in California, and I'm the subcommittee chair. So a lot of those patients, along with some other providers, filter through me.
Oh. And for the palliative care fellows, these are not necessarily oncology fellows, right? I mean, you could be like a primary care physician and you decide to do
Exactly.
fellowship, or a geriatrician. So
Yeah.
what do you say do you have like a breakdown? Like how often you get an oncologist medical oncologists who want to do extra fellowship in palliative care versus non-oncologists?
Yeah, I haven't seen that at our center, but I have known many other people that have done it. For example, we have some faculty in City of Hope that actually have done oncology fellowships and then gone on to get palliative fellowships. But I'll tell you, with our particular program, we have had critical care physicians that have done an ICU fellowship and then come to do a palliative care fellowships. We've got pediatric fellows that have come and done the adult hospice and palliative care fellowship as well. So that gives them the whole spectrum of treatment. Like, for example, my primary residency was in pediatrics, and then I chose to do an adult hospice and palliative medicine fellowship because that allowed me to treat everything from in utero all the way to old age, right? To the aging population. So I think it was important for me to get that spectrum because, there are some differences in how you approach palliative care with pediatrics or with the society or with those that are aging and the middle tier. But the core principles of palliative and end of life care are the same.
Yeah,
and so
yeah.
someone who's trained in palliative care should be able to really approach palliative care for all patients of all ages.
Right. So, I wanna segue a little bit into just a little of communication because I think that when I was in training, there wasn't really anything to teach me how to communicate, frankly, whether it is good news or bad news. And I'm not sure if there are such classes, to be honest, but basically I learned how to communicate with my patients through just watching my attendings. And you kind of take like a nuggets from this one and a nugget from the other one. Sometimes you don't like the style of this one, you like the style of the other one, and you just kind of pick and choose. And then through my own experience, I had lots of pitfalls and some success, some pitfalls, and you kind of stumble and learn what to say and what not to say. But that was during my training. I really felt I was ill prepared to the real world when I actually walked in and I started to see my own patients. It's always easy to say, your scan is perfect, you're cured, you're doing great, right? But, when I'm walking into a patient full of my family members and things look awful, I really was not prepared at all. And I think families and patients are smart enough to recognize when the physician is comfortable or uncomfortable. Some of them are gracious, where they actually understand that you're nervous and make it easier on you. And some of them are not, because they're also under a lot of stress. So this is such a long intro, and my listeners know I don't like to do long questions, but I really wanted to put this in context because where are we now? Are we training people? How do we train them? And do you feel that the next generation of physicians is really equipped to handle stressful, difficult communication? Lots of questions. So let's start by where are we now in terms of teaching?
Right. So that's an excellent set of questions because for me, I do believe communications is at the core of everything in palliative care. So one of the things I'll tell you is that I really didn't learn the art of communication until I got to palliative medicine in my fellowship program, right? And then developed that style or technique after graduating from that fellowship program. And when you look at really what's happening out in training right now, and specifically graduate medical education training or even medicine, right? Medical schools, that training is not being formalized enough. I'll tell you this, that in medical school, even now, there may be maybe one or two schools, even in the US, that even offer any kind of end of life training, right? How to take care of people that are dying. Let alone a communication training. We in palliative care, I think, as a field, are very conscious about that because we always have to have conversations with our patients. Not only with our patients, we have to have conversations with other providers, and we have to have conversations with patients' families. So communication is central to how palliative care works. And so in palliative care fellowships, you'll see that even though it's not a formalized communication training, it is part and parcel of your entire training. So that's the one advantage that we have, that even those that are uncomfortable going into palliative care with communication skills are going to come out of it with a pretty reasonably good set of communication skills of how to approach families. Now, I found that the best teacher is reality, and being able to be with our patients and to learn what their desires are, to learn what they want, is the most important aspect of any of these conversation pieces, right? And I think that should start very early in medical school, which is not happening even today. And I think it would help society to actually create a specific course in communication on serious illness. Because when you look at communication on difficult conversations, it's not only just at the end of life, but it's having them during serious illnesses. Even breaking news to someone that you have to be on an LVAD for the rest of your life. That is as serious to some people, and it should be, as someone who's been given a terminal diagnosis with cancer. So communication becomes really a core at this. And if someone is not comfortable communicating this information, they're going to cause undue stress on the patient and their families. And then that is the biggest injustice that we can do to the people that we're taking care of, right? So I do feel that you can never educate them enough. Education, 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 practice, practice, practice. I think medical students, residents, and fellows should be thrown into these situations, whether it is in reality or through simulation, to really deal with how to communicate. We all have different communication styles. Mine is very different from yours, then it's different from the other physicians. But we all learn, and we all learn to come to a common understanding of how we want to help each other and our patients. So I feel it's important for medical schools to start a curriculum in communication and in end-of-life care early. I think it's very important that physicians in residency and fellowship do get formal training in communication styles. We all talk about the spikes model and how to situate yourself, the environment. But again, when you're thrown in that situation, many physicians get nervous. And everything, all the theory we learn goes out the window. So we need to learn to address it in that real moment and that real time. And only practice is going to do that. The other thing is, I think, things like the symposium and other institutes that work with palliative care and with end-of-life care do offer communication training. Anytime we have to deal with palliativists, it's goals of care training, advanced directed training.
How is that done? Like, do you role play, simulation?
There's role play, the simulation, there's actually doing it firsthand and then getting feedback. And what I feel often is amiss is that, yes, physicians that are in training are getting feedback from their peers and their attendings. But I think we need to get feedback from patients.
Right, exactly.
We need to ask them, okay, how would you have liked to do this differently? How could I have done it better? Right. And ultimately, the way I tell my trainees is that, why don't you imagine this, any patient? And that's how I approach patient care. Ever since my dad died, my approach to every patient care is that who I'm caring for is my family member. And how would I want things done for them? How would I like things approached? So, when I go into a patient room that I have to discuss this breaking news that they're terminal, or they have to sign on to hospice, I think it's important to form that connection with them, because as palliativists, we don't often get involved early. Sometimes we get called to discuss that ultimate news of them signing on to hospice. And my personal preference at that point is to sit with the patient and really understand, what is it that they know, how much do they want to know, and what is it that they're looking for moving forward, because then that helps me really look at the way I'm going to communicate with them, right? If they're crying, if they understand that something is not right, that is not the best time to communicate that news. And people need to give people space. And then you need to come back in to discuss that news, because when they are stressed, they are not going to absorb what you're telling them. So even that is an art, like when and how to break that news to them. So is there formal training in programs right now? I would say very few places are doing it.
Yeah.
Should there be? Absolutely. I think not just for palliative care, but I think throughout all medical specialties.
Yeah. Timing, you hit the nail on the head. Timing is so critical. And I think when I look back at my career, that was probably something that I've learned with
Yeah.
time to pick the right time and to say which is what. And that's why I had issues, for example, when some administrators or even payers say you must discuss code status within like the first two visits, otherwise you'll be penalized. And I'm thinking, well,
Right.
that really takes away from the fact that there's an actual human element to this, and maybe it is the first visit, but maybe it is the third visit. You have to read the
Exactly.
room and make a decision when is the right time to have a conversation about this.
Exactly. And I think that is really that's the art of humanity, right? I
Yeah,
think we're all humans, and sometimes, we concentrate so much on the discharge numbers or the length of stay that we forget
right.
that there's a person in the middle of all of this. There's a soul, there's a human being
And
that
that person
could
is going to be us one day, Chandana. I mean, it's
exactly,
gonna be
that could
us.
be
It's gonna be
us.
me in that room, unfortunately. So,
Exactly.
so if you try to think about the common, I guess, pitfalls in communication among healthcare professionals when it comes to end of life care, are
Yes.
you able to like think through like, these are the top three based on your career observations, research, where you
Mhm.
really feel these are three things that when you take the healthcare providers as a whole, they kind of trip a little bit on them.
Right, I do. I'll tell you this, that I don't think in general, we're getting better, but I don't think those of us that practice cancer care or even serious illness are very good to start with in terms of knowing how to communicate news that is not to your liking. For example, oftentimes you'll hear, hematologists, oncologists are afraid to break this news, or they don't want to accept this news because sometimes they think it's a failure on their part. I
Right.
think we have to change the mentality of how we approach end of life care. I think everything lies in that, right? You know, I think if people or physicians taking care of patients that can possibly proceed to end of life at some point in their disease trajectory should start having these conversations with them in small size, bite sized portions from the very beginning, right? It may not be the first time that you meet them that you're talking about advanced care directives, but the second and third time, I think it's fair to ask them, what would you like for yourself? What if things don't go right? How do you proceed? That's not saying that things won't go right, but you want to be prepared for the worst while doing everything you can to make sure that we're working on helping them with their cancer, right? Or the serious illness. What would the patient like if they got admitted into the ICU? What are their preferences? And all of this falls under really the communication aspects of goals of care discussions, of advanced directives, really of really looking at the patient's philosophy when it comes to their end of life and their quality of life. I feel that these conversations are left or buried by most people until the time comes at the
Can I
very end, which
interject
is
here?
wrong.
Yeah, I
Yeah.
want to interject here just a little bit because, and this is really purely based on sometimes my observation, and sometimes as I lay in bed and just think about things, it just
Mm-hmm.
these things cross your mind because we're all humans. But I think sometimes your decisions vary based on your health status. Like if you ask me today, if you
Yeah.
ask me, hey, Chadi, like, what do you want? I may say I'm DNR today and I don't
Yeah.
want like I'm like, I feel good. So it's easy for me to say
Yeah.
I don't want anything done. Now, put me in a different situation. Like, now you ask me the same question where I'm in the ICU and I can barely breathe and I don't feel well. I'm going to probably tell you, do everything you can because I need to breathe better. I mean, I don't really care
Right,
what I told you when I was feeling good.
right.
I need to
I
feel better. So that's, I feel sometimes these conversations it's easier to have when the person is feeling well,
yeah,
but what the person wants changes based on how they
changes.
clinically feel.
Absolutely. And I think, most times you'll see that the patients end up making the right decision for themselves. We hear about these outliers, and they are outliers where, a patient knows that they're dying and wants everything done. I'm surprised that I find most of my patients make the right decisions. But what's important is also that I continue having these discussions with them throughout my relationship with them. Because, yes, like you're saying, situations can change. And what we as physicians have to do is one, make sure that they're fully informed as to what is happening to them and what the prognosis is, which is something that we all trained to do. But I think ultimately it also is important that we respect the patient's wishes, right? I think that's also important. I think there can be a compromise where we come to as a provider and a patient to reach that perfect situation. And usually, I find that when providers or physicians, nurses, and patients work together, it's always the best outcome that happens for the
Yeah.
patient. It's usually when the patient is very reluctant to listen or the physician is very reluctant to provide that information. That's when the outcomes are not as much healthy or I would say peaceful as they should be.
Denial is one of the biggest emotions that people have. And
Yeah,
sometimes the denial is on behalf of the patients and sometimes behalf of the families. Also, there are patients who want to go the extra mile no matter what because they feel they're doing this for their families. They
yeah.
really have a goal they want to do. Um, how do you deal with denials? Because there are certain facts
Yeah.
and it seems like your message is not coming through.
Right. And we've had so many of those patients. I'm sure you've had similar patients too, where they just don't hear it. Um, it's not only just denial, but it's also, the fact that they do think about their families and this idea that even families, when a patient's on a vent, doesn't want to take the patient off the vent, is something that is very real. I mean, in ICU settings, many times you'll see family that is also in discord with each other, the members of the family, over a patient who's vented that actually is not going to be coming back, that has lost function of their brain, that has had organs shut down, but then they still want to keep the patient on the vent. What happens in these extreme cases, right? I think we as physicians and clinicians have the due diligence to not only, again, educate the family members, or if it's a patient that's in that position, the patient, but I think we need to address every aspect of that care. So we need to bring in the support teams that we have, right? Our social workers, probably who are the best trained in terms of having communication with patients, our chaplains or spiritual care individuals, because sometimes if a patient or a family member is spiritual or religious, that is the best language that'll reach them, right? I think also making sure that we support them with things that they're worried about. Sometimes, religion demands that they need to be on a vent for a certain time, or let's say, when it comes to someone who's denying to take opioids when they're in severe pain. Sometimes some cultures um, don't look at taking pain medications very favorably. So all these things become something that we as providers have to be conscious about. The way I look at this is that, we have an ethics committee, you bring an ethics committee on board, but the ethics committee is only going to be as good as how culturally competent and educated they are. So I think that's another piece of this puzzle, right? Do we understand the patient and the family as well as we should to have these conversations with them, right? Understanding end of life practices or understanding medical practices as how other cultures view them is also extremely important in this piece. Because if we are not on the same page or we don't understand where they're coming from, they are going to be less resistant. They're going to be more resistant to us and to listening to what we have to say. And at that point, denial becomes a major aspect of it. I am not listening to you because one, I don't believe in what you're telling me, and two, because everything against me, everything about me tells me to go against it, right? So you have a double sword of denial there. So I think it's important not only to approach the whole person, mind, body, and soul, in terms of taking care of them, but also working with their families and their culture to understand how best we can work with their disease and their prognosis.
I think the culture and the religion aspect that you brought up is so important because these vary, and sometimes there are certain limitations that obviously we have. And I think bringing like a religious figure for the family or an ethics committee is so important. And I know there's so much I could talk to you about, and I know you're probably going to be pressed on time in a little bit, but there are a couple of things I just want to get through really
Yeah.
fast.
Mm-hmm.
One of them is, how much have you seen fear of death really plays a role into this? Because I think sometimes, and many times, even for the healthiest of us, we have the fear of death either for us or our loved ones, and just not knowing that we're never going to see them again.
Yeah.
Have you seen that as a barrier? And this is such an emotional topic. Like, I don't know how we deal with this, to be
Yeah.
honest.
Yeah, I've seen that a lot. And I think as palliative and hospice physicians, we see a lot of that because we are often encountering our patients really when time has come for them to say goodbye. And I often find that fear of death is twofold. One is their own fear about them leaving this earth. That's one, right? And how they're going to die is incorporated into that. Many people fear dying in pain. They fear that they're, for example, someone with COPD, I've seen, they don't want to feel like they're drowning and suffocating at the end of life. So that fear is very real to patients. And I think that's something that we should try our best to make sure that we put together an end of life plan for them, that it doesn't happen, to sort of make sure that their fears are addressed, right? The other fear I see is them leaving their loved ones. I think that's the biggest fear. It's like, what's going to happen to my 5-year-old daughter once I die, right? What's going to happen to my son? What's going to happen to my father? My father doesn't want to see me die before he does. So that fear and how to realistically approach it is another thing. It's a lot of existential fear. It's a lot of emotional fear. It's a lot of psychological fear. And I think to address this is through conversations, is to get our support teams involved, is to get our psychologists and psychiatrists involved, because everyone who's about to die or knows that they're going to die in 6 months is going to be depressed. There's no denying that. If I was told today I'm dying in 6 months, of course I'd be very depressed. And I and my family may not have the right tools to work with me. I would need the help of someone to talk to me about this, to help me address my fears. I don't think we utilize our support services enough to address fears that patients and family members have. And I think that's something that, like you said, there is fear of death, whether you like it or not. I don't think I've met a person, and maybe there are people out there that say, hey, it's okay, I'm going to die, I don't care. But most of the people I meet, yes, they are fearful of it because they don't know how they're going to die. They don't want to die suffering, and they don't want to leave their loved ones in bind. So again, advanced care planning, decision making,
Yeah.
making sure that everything is addressed before you reach that point is another aspect of helping that fear.
This is really such an important topic about how to handle the fear. Totally correct. My last question is, what type of research does your field do? Like when we talk about palliative and hospice
Yeah.
care research, I mean, I don't know, what kind of studies, what kind of things that you usually focus on?
So, research wasn't really big in palliative care until it was brought to light by Jennifer Temmel, who did
Yeah.
studies that showed that, even signing on to hospice can prolong life, right? And that's when, something clicked. There's been a lot of research in palliative care after that. There's been research on how certain medications or certain alternative therapies can help with symptom management, right? There's research in spirituality and how can spiritual care address existential fear at the end of life or even in palliative care.
Right.
There's research in really medical aid in dying, which is like really a hot topic right now in terms of like how medical aid in dying also is important in opening end-of-life conversations overall, right? I'm doing my PhD in palliative care as at this moment, and my area of
You have
focus.
time to get a PhD. What?
So my
Do you
goal.
sleep?
Sometimes I can get 6 hours of sleep if I can.
I don't believe you. Okay.
I do. So my goal, but it's in a field that I love. I think that's the other thing, right? I think if you're doing something in the field that you love, it doesn't become a chore. My focus is on medical aid in dying specifically, in looking at really, education and looking at how this field has been an opener for communication for all sorts of serious illness. There has been research in looking at bereavement and looking at anticipatory grief and grief in palliative and end-of-life care. There's more and more research coming out specifically looking at how certain drugs work on symptoms in palliative care. That's happened for a while, but I think they're getting even more refined as we speak. There isn't as much research as should be, I feel, still in communication aspects at the end of life, right? There is, but I think if we look at the fact that communication is at the core of everything, there should be more and it should be more comprehensive. So that's another opportunity for someone out there who wants to take that on. But I think there's so much more that can be done in this field. I think one of the key things is that, other fields of medicine, as they embrace palliative care more, which is happening more after COVID, when they saw really palliative care was a field and end-of-life care was a field that these specialists could come and help the other teams with when patients were dying. I think you'll see that research that is multidisciplinary and integrated with other fields of medicine is going to come up more. I think other fields are going to utilize the strengths of palliative care and work to create even a better field overall for patients.
Well, you're doing amazing work, and congrats to everything that you're doing. Before I'll let you go, Chandana, is there anything I should have asked you that I completely overlooked or forgot, or you think there's a particular thing that you want to leave our listeners and viewers with?
Sure, a couple of things. One is that, if you have the chance to check the End of Life Symposium that City of Hope offers, please do that. You can find that on our website. The other thing is that, especially if you're talking about end of life and cultural competencies, I did put out a book. I was the editor for the CTAR series. It's called Understanding End of Life Practices, that book specifically. It talks about end of life from not only communications, but culture and modern aspects of end-of-life care. So that's something that's a great resource to look at. And Dr. Stephen Rosen, who you know very well, was the series editor for that book. The other thing I would like to leave with is a little bit of self-help for people. I think the fact that we are all going to approach end of life is something that we need to think of as we think of life itself. I think those of us that are patients and caregivers really need to learn to ask the difficult questions to our providers. We need our providers to give transparency to us in that conversation. And we need to really be a part of our own care, because the best care you can get is when you are in collaboration with your healthcare team to get the care you need, whether it's a curative care or whether it's the care at the end of life. I don't think good quality of care can happen if you're not in partnership with each other. And I think that's the most important thing. I think we need to count on each other to make sure that this is something that we all do the right way.
Dr. Chandana Banerjee, thank you so much for coming on Healthcare Unfiltered, and I'll be linking to your bio in the podcast notes. I really appreciate taking the time of your busy schedule to be with me.
It's an honor to be with you, Chadi. Thank you so much. Thank you.